We'll be starting shortly, waiting for a few more people to join us. We're starting shortly. We have close to 100 participants now. Thank you for joining us from Cardio Care Hospital, Abuja. Thank you for joining us. We'll be starting shortly. All right, we have about 90 participants. It's 3:08. I think we may be starting now. Maybe I hear from my side, Dr. Inuwa. Should I share from my side or you share from your side?
I can share from here, sir.
Okay, go ahead.
Is any need? Which one is my choice, please? Okay, that's it. Okay, remove this away.
Okay, so you're still sharing your screen.
Yes.
All right, so let me just introduce. My name is Dr. Iseko. Right in Cardio Care Studio is Dr. Inuwa. We'll be presenting advanced cardiac life support. This is a clinical approach. You should be able to brush up your ACLS. You should be able to know what to do. It's not 100% because there's no practical session, but we hope to do more of ACLS this year in the Abuja Cardiovascular Symposium. So get ready this December, first week of December, with respect to the Nigeria's largest medical symposium. We're reaching you from Cardio Care Hospital, Abuja, here in Nigeria, and Cardio Care is a multi-specialty hospital. It's a center of excellence for cardiovascular medicine and surgery, interventional cardiology, stents, pacemakers, and everything that everybody travels abroad for in cardiovascular medicine. That's Cardio Care. Dr. Inuwa is a senior cardiologist. I'm a cardiologist there as well as an interventional cardiologist. And we have loads of other members of our team. We are happy to be here today, and we'll be going on with a clinical approach to advanced care. So Dr. Inuwa, over to you.
Okay, thank you, sir. Good afternoon, everyone. We'll be discussing advanced cardiac life support today. I hope everybody had a nice day or still having a nice day so far. Okay, so we will be discussing ACLS under the following outline. We want to introduce what it's all about. And I'm sure a lot of us are already, this is not a new topic. It's just all about brushing our skills and reminding ourselves of some of the things that we already know, or maybe we don't know, and now we need to know. And then we're going to discuss the important rhythms, both for the cardiac arrest rhythms and then the non-arrest rhythms are also important. So ACLS, what's it all about? Advanced cardiac life support. You know, it's a continuation of the basic life support, which we all know it's all about resuscitation, your CPR, your cardiopulmonary resuscitation. So this is what happens after you're done with your your basic life support. The patient gets to the hospital, and then you need further care. So advanced cardiac life support is a standardized algorithmic set of treatments used to treat life-threatening cardiovascular conditions. And it's a set of clinical guidelines for urgent and emergent treatment of life-threatening cardiovascular conditions. So we're talking of emergencies here, and will cause or have caused cardiac arrest using advanced medical procedures, medications, and techniques. That's why I said at this point, the patient is now in the hospital, because your basic life support initially could be anywhere. The patient could actually still be from, it could have happened in the hospital, it could have happened anywhere on the, by the roadside, marketplace, just anywhere. So once you're done with your basic life support, giving your CPR, obviously you would have called for help, and then the help is coming to give advanced care. And then if the person is not in the hospital, the person is being brought into the hospital for further care. And if the person is in the hospital, good, we can now give all the supports and care the patient needs. So as I said earlier,
just to add to that, please go back to the previous slide.
Okay.
Just go back to the previous slide. So just to add to that is that don't worry yourself with the word advanced. A lot of times when everybody hears advanced, they are already afraid that, oh, there are some big things. No, it's just, this is what you do when you see this. So there are some things you need to have when you call it advanced. That's what it means. Basic means you are using your hand, CPR, ambu bag, oxygen, maybe an AED. When you get to advanced, you have to interpret an ECG and then give some certain drugs. So number one, you need an ECG monitor. Number two, you need a defibrillator. Number three, you need drugs. And knowing what to do when is all that is about advanced cardiac. That is the basis of advanced cardiac life support. So before I became a cardiologist and so many others long ago, when you hear ACLS, you're like, this one is for the big people. No, I want all of us to relax and just know that it's just a set of things you do. When you see this, you do this. When you see this, you do that. That is all. And you just have to try and remember it and practice it over and over again. Luckily, this video will also be on our YouTube page, so you can watch it again and again. Dr. Inuwa, over to you.
Okay, sir. So we'll have to talk about briefly just what basic life support is all about, which we already know. We'll just have a recap and then talk about crisis resource management, how to identify the different rhythms, because that's what the advanced ACLS is all about. You know, how to identify different rhythms, what to do, when to shock, what type of shock, what medications to give, and how to help the patient when there's return of spontaneous circulation. So going through basic life support briefly, we already know that once there's somebody that needs help, you find somebody that is unconscious, first of all, we know the usual thing, we check for safety, ensure that wherever you are, that you're trying to give help, the place is safe. If the person is on the roadside, the person is out of maybe major traffic, you know, if the person is in water, you brought the person out, you know, there's safety around there. Then you check for responsiveness. I'm sure we already all know all that. Where you palpate for the carotid, you look at the chest elevation to see if there's respiratory effort, and you call the person to know if the person is responding. If you've done all that and there's no response at all, you can't feel any pulse, you've called the person is not responding, no respiratory effort, you can't see the chest moving, then you know you are calling for help. It's important to call for help because we know we can't do it alone. You would get tired, and at the end of the day, the whole essence will be lost because you need help. And then any which way you need to call for help. Either you go out, you call, shout, or if you have a phone with you, you call someone, call the hospital, or if there's an emergency number, whatever you have to do, you need to call for help. And then if you're even in the hospital setting, you call for help because there are other people that are in other aspects of the hospital that needs to join. Like here in cardio care, everybody here is trained, even to the security men, the housekeepers, everybody is trained to know how to do CPR, because when you really need it, you need all hands on deck, and then you need everybody involved, because you could get tired, you need somebody else to take over, and it's a teamwork, so everybody knows what to do. And of course, as you're calling for help, you're telling the person, oh, bring the AED, bring the crash carts, you're assembling everybody, and immediately you start CPR. You're not wasting time because every seconds matter. So you're starting CPR, we know the usual 30 to 20, 30 compressions with 2 breaths. We already know how we try not to have minimal interruptions. You just continue CPR continuously, ensuring that you're doing about 100 to 120 seconds per minute. You're ensuring that the depth of the CPR is a depth of about 5 cm, and you allow the chest to recoil, and then you continue again, and then you keep going on and on until the AED is brought in, so that you can now attach the pads and then check the rhythm if it is a shockable type or not. And then, of course, that's what this whole presentation is all about, on what to do. While we are doing all that, it's also important to understand what crisis resource management is all about, because that's what will help to make this resuscitation successful, because there is a teamwork and there should be somebody in charge. So as you've gathered, or as in you've called, you're in the hospital setting, you've called everybody, both the nurses, the doctors, everybody on ground, anybody that is available, everybody is there. There must be somebody that is a team leader to direct and ensure that everything is done properly and done well. So there are 3 key principles under the crisis resource management, because this is key in ensuring that you're giving adequate CPR. So the leadership, communication, and preparation. So for the leadership, one person, as I said, must take that role. As everybody gathers and you started CPR, somebody is obviously saying, oh yes, I'm the one in charge, and you're ensuring that the tasks are carried out competently. You're coordinating communication between teams. If you want a particular medication to be given, you're saying it clearly. I want IV adrenaline, 1 milligram, starts, and the person is also responding, adrenaline 1 milligram. So everybody knows, yes, that is what you are drawing out, and that's what you're about to give. Everybody's seeing what is going on. The team leader is coordinating and ensuring that the CPR is being done properly. The person giving the breaths is doing adequately. There's enough, there's adequate chest compression, medications are given. The one taking sample is taking sample to ensure that you are trying to rule out causes of what has caused the person to lose consciousness and all. And then you're assessing performance throughout resuscitation, so that if there was any error or anything that's gone wrong along the way, when everything is done, you can, go back, everybody sits down and then document, okay, what happened, what did we do right, what did we do wrong, what could have been better, and stuff like that. So it's very important that there's somebody in charge. And then communication is key. All pertinent information goes through the team leader. Tasks are assigned by the team leader to the team member. So there's no confusion. Not that someone is saying, no, it's Adriana, no, it's Amil, no, it is this. The team leader is the one in charge, coordinating everything and ensuring that as he or she is giving out instruction, the person is giving out the instruction to knows what to give, and the person is replying back saying, this is what you've asked for, and everybody knows what is being given. And it's very important that there's somebody also documenting all these things going on, because at the end of the day, you want to know how many adrenalines have been given, how many shocks have been delivered. You are able to give account of all that has been done. And then we talked about debriefing the team for learning points after resuscitation.
Just to say that,
okay, sir.
The team leader typically should be the most senior person in the group. Typically, should be the most senior and most experienced person. Sometimes the most senior person does not have any ACLS training, and so that senior person can assign the team leadership to somebody in the team that has had ACLS training. So if you are somebody in your team and you have had the ACLS training, you become the team leader. You are making sure of certain things, that everybody is doing CPR properly. So when I get to the CPR scene and CPR works, CPR, ACLS works. There are lots of our patients that are working and alive today because they had good ACLS. So when I get to the ACLS team, maybe the medical officer was in charge before I got there. As I get there, the person moves on and I become the head of the team. Immediately people start doing CPR. I have to change some people doing CPR because they're not doing proper chest compressions. You have to make sure that everything is being done properly. You've assigned all the roles, the documenter, the compressor, you check the airway, you check the oxygen, you check all of that. That's what the leader is doing. Now, in addition, the leader is also checking those that are getting tired. Once they start getting tired, to know when to switch. Typically, if you try and switch 1 to 2 minutes, every 1 to 2 minutes, people compressing should switch to somebody else. So this is one of the things. So when we get there, there's no need fighting over who's the team leader. The person that has been trained or the most senior person in the room becomes the team leader in that moment. And then somebody takes on the recorder, somebody takes on compression, somebody takes on airway, somebody takes on medication, somebody gets the defibrillator, and somebody connects them all while compression is still ongoing, so that you can be the one thinking. All right, thank you. Please continue.
Thank you, sir. So as we're talking about the teamwork and all, with the team leader coordinating things, we need to understand that the team leader also, as he has mentioned, is the one saying, okay, this person is in charge of giving medication, this person is in charge of doing CPR, this person is in charge of monitoring oxygen, this person is in charge of ensuring the shock is delivered. You know, everybody has a role to play. While all that is going, the person that is setting the line is setting the line. Most likely there's a line already because the person is already in the hospital setting. Oxygen is being delivered, there's somebody in charge of it. You've connected the monitors to obtain an ECG reading so that you know what's going on. The person that, of course, has brought the aid is bringing the cash cards, advanced airway, everything is going on because everybody has a role to play and they're doing different things. So this is just showing you a list of all the things, you know, about 2 to 3 CPR performers needed so that they can be rotating it, because of course, when we get tired, and if you're tired, you know, you will not be able to give adequate CPR. So you need to take it in turns. And then of course, it's we need the anesthetists are available, you know. The person in charge of the monitor is there. The person recording, it's always very important that there's somebody recording all that is being done, you know, so that you're able to take account of what has been given. Not that, oh, was it, when did we give our meal that run? Someone say, no, we gave 2. No, someone's saying we gave, no. But once it's recorded, everybody knows that, yes, oh, no, it was just one given, we need to give another. Or it's time, because adrenaline should be given 3 to 5 minutes. Oh, it's time for the next one. We've just given one. Okay, we need to give the next one. So everything is done orderly because everybody has a role to play and it's well documented. So there's no confusion. So it's important we understand, because at this point in time, while you're doing your CPR and all that, you've connected your pads, you need to know whether this patient needs to be shocked or not. So it's important to understand the difference between defibrillation and cardioversion. It makes use of the same machine, but you need to know what to do and when to do it. So talking about defibrillation, defibrillation is the one we normally do when you're talking about resuscitating somebody that, you know, the person is not breathing, there's no pulse and all that, you know, and it's asynchronous electrical discharge. It's very important to understand that it's asynchronous electrical discharge that causes depolarization of all myocardial cells at once. So it's like you're shocking the heart, you know, you're shocking so that the SA node can pick up because you can't feel any pulse, there's nothing going on. So you're shocking. It's like a passing electrical, what's it called, current through the body to the heart so that it can pick up. And of course, for the defibrillation, it comes in different, the different shock energy depending on what type you're using, either a biphasic or a monophasic. Although, well, the newer ones now come as biphasic. So the joules given is lesser than that of monophasic. Monophasic, we go with the higher joules. Biphasic, it's lesser, 120 to 200. But if in doubt, just better to step up to your 360 joules if you are not sure which one you're using. But if you're conversant with your AED in your center, you should know what type it is. And then when we talk of cardioversion, that's why I mentioned the other one is asynchronous. This is synchronized conversion you're doing. So this patient is not the one that does not have a pulse. This person has a pulse, but of course, the pulse is either too fast, too slow, you know, so you need to do something about it. And the cardioversion is electrical impulse is discharged during the QRS. So what we said is synchronized. The term there, synchronized, is important because when you're cardioverting, number one, the amount of joules you're giving might not be as high as that of defibrillation. Number two, you are synchronizing it in the sense that there is the ECG reading going on while you're looking at when to shock the patient. And it should be directly on the QRS complex. We don't want the shock to be delivered after or before. It has to be on. If not, it will cause more harm than good. So we want it directly. That's why I said it's a synchronized thing. You have to, and patients like this, you would have to even sedate them because they are awake. It's just that they're having arrhythmias and it's becoming really bad. So, and they're very unstable. So you might even need to sedate them as compared to the defibrillation where this person is already unconscious. There's no even, you're not even, you don't need any form of anesthesia. At that point in time, you just need to, you're thinking of, you're resuscitating, So this is what the ECG tracing is like when you're doing cardioversion. You see like an abnormal reading.
For practical purposes, when you have, is the machine there? Can
yes,
we focus,
yes, sir.
can we focus on the machine? So for practical reasons, when you have your machine like this in the hospital, and try as somebody that has been on this webinar to go and advocate for a machine like this. So let's focus on the machine. For practical reasons, when you look at the machine, defibrillation and cardioversion are virtually the same. The main difference is that in defibrillation, you typically are using maximum voltages, typically 200 and above, and you are shocking without synchronizing. While for cardioversion, can we focus on this, Mr. Enokela, Mr. Victor, Pamela? Can we focus on the machine? While for cardioversion, you will take this machine, it has an ECG connection port. You will connect the ECG to the patient. You will see a reading strip like the one on your screen. Now that Dr. Inuwa has shown, you will see your reading strip on that ECG. You will press a button on the ECG that says sync. And then when it syncs, it will sync to each button on this QRS. So if you look here, can we see the QRS now I put in blue? The peak of each QRS, I put in blue there. I put in blue there. So once you connect the ECG on the machine to the patient, then you will press the button sync. The machine automatically identify each of these QRS complexes. You need to check it and make sure that it has identified it properly. Then after you have synchronized, you now give. Typically, you are given a lower Joe, 50 to 100, or sometimes 120 to 200, but typically 50 to 100. So you are given a lower Joules. You must have connected the ECG electrodes to the machine. Then you must press sync, SYNC. It's on the machine. If you take a closer view of the machine, you will see where she's pointing there. It's on all your machines if you have this machine. And if you don't have this machine, you need to get one. You need to get one because you cannot save patients without it. You may not have enough time to transfer the patient to cardio care, but sometimes some patients are able to be transferred successfully and we are able to do it when they've transferred, but you should know how to do it. So you will not press that button that says sync. The different machines have different formats. What if we're in the village? If you're in the village, you cannot do ACLS. If you're in the village, you cannot do ACLS. If you're in the village and you don't have these things, you cannot do it. So you need equipment to do ACLS. So when you press sync, the machine will pick it up. Now you can see at this point here, this is where the shock was given. And then immediately the ECG has become normal again. Or in this one, a normal heart reading. So if the machine does not sync, the shock will be given anywhere, and that can lead to a ventricular fibrillation and put the patient more at trouble, more at risk. The patient can actually go into a full cardiac arrest after this with no pulse. So very important. If somebody has a pulse and is having an abnormal reading, don't defibrillate because that will stop his heart. Anybody that has a pulse, don't defibrillate. If they don't have a pulse and they have an ECG that needs cardioversion, you make sure you synchronize. We'll show you those ECGs just like this one. Make sure you synchronize. Then you now deliver your Joules. You will see at the top of that picture there, you can see there is a dosage selector. We can select the amount of dose of voltage that can be shocked. So you can see where she's pressing plus and minus there. You can select the voltage that you can use to shock. So you now select it up to 100, 50 to 100, and then in a child, much less, in someone that is bigger, much more. And then you now deliver the shock after sync. After you deliver the shock, if it doesn't cardiovert and you need to do it again, you need to synchronize again. ECG is connected, you click synchronize, and then you do the same thing. Now, if it is for pacing, if it's a slow rate, you will just turn that same thing to pacer, and then you press pacing. You say you cannot see the machine. I think you can see it now. Click on it, you can see the video that is there. You can see the video that is there. Okay, so if you look at Dr. Inuwa's video, if you look at Dr. Inuwa's video, you can see it. Okay, thank you. You are now seeing it. So you can see the machine again. So what I said for the machine is, number one, the machine has a place to connect your ECG electrodes. At the top of the machine, you will see the ECG showing on the top of the machine. After that, you will press the button to sync. Synchronize will put this kind of arrows on EQRS, check that it is correct. After you have done that, then you change the voltage using that plus or minus sign. Different machines may be a dial, it may be something, typically to 50 to 100 joules. And then when you are sure it has synchronized, you make sure everybody has cleared. Nobody should be touching the bed. The bed should not be metal. Nobody should be touching the bed. Nobody should be touching the patient. And then you now synchronize shock. And then you now do it. I hope that is clear for everybody, just to make it practical. So cardioversion, lower joules, cardioversion, synchronize the shock. If you don't synchronize, you're going to cause a cardiac arrest. Cardioversion, patient may have a pulse. Typically, patient is conscious, but is hypotensive. Defibrillation, higher energy, it is non-synchronized, and it's just to stop a cardiac arrest. Okay, so over to you, Dr. Inuwa. If you have questions, please put them in the Q&A. If you have questions, please put them in the Q&A, and we'll get right back to them. Okay.
Okay, so we still have the, okay, it's off now. Thank you. Okay, this just shows that, hello, sir, are you there?
Yes, I'm here.
Oh, okay, all right. So this just shows the things we need to do while, all that is going on, while you're shocking the patient or not shocking, depending on whether it's a shockable or non-shockable rhythm. We've mentioned all this. You are monitoring the oxygen saturation. You need to sanction when needed, and then you're sorting out. We've talked about analgesia, especially for our cardioversion. Then the other thing to ensure is what rhythm you are saying, because that is very important. Successful ACLS treatment starts with the correct diagnosis of the ECG rhythm. You need to know what type of rhythm, because that will determine what to do. And if you miss it, you might miss an opportunity to resuscitate this person. So it's important, and we all should know all these rhythms that are very important for our ACLS. So we try to make it simplified by dividing it into groups, in the sense that we've talked about the cardiac arrest rhythms and then the non-cardiac arrest rhythms. So the cardiac arrest rhythms, we've talked about, these are the ones that this person, you started CPR on, the person is, there's no pulse, person is not responding, no respiratory effort, and then you started your CPR and all that. Please put your pads. You're now checking the ECG rhythms, and then you're seeing either a ventricular fibrillation, pulseless ventricular tachycardia. We'll show you the ECG tracings later. And then, or is it pulseless electrical activity or asystole? These are the 4 types of cardiac arrest rhythms we are looking out for. And then the other type is the non-arrest rhythms. That's for those ones, this patient have a pulse, but they are having other arrhythmias. It could be a narrow complex tachycardia, referring to the width of the QRS complex when it's less than that's less than 3 small boxes, that's about 0.12 seconds, and then wide complex when it's more than that, or bradycardia when the heart rate is less than 50. So once you're able to divide this, as you're seeing in your head, you've divided it, so you know what you're looking out for and what to do, because you do different things depending on what you can see on the ECG tracing. So starting off with the ones that have no pulse, this is the patient has a cardiac arrest. You are thinking of Are we dealing with ventricular fibrillation, pulseless ventricular tachycardia, asystole, or a pulseless electrical activity? So these are the ECG tracings, trying to differentiate all of these.
Snap this page.
Yes, sir.
Everybody that's on this call, I can see over 160 people on this call from all over the country. You need to remember these rhythms. You need to have it. If you join our WhatsApp group, we will try and post something you can print and put on your wall. But please have this in your mind. You should know these rhythms. These are rhythms you should know. Somebody has stopped breathing and you have been called, they've been doing CPR, you put your ECG first as they are doing the CPR, you now look, you should be able to identify one of these rhythms. Please, 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 you need to capture this in your mind's eye. Capture it in your mind's eye. And then you can see this one that is asystole, that is flat. It does not mean the patient is dead. That is only in the movies. That will say flat line, patient is dead. This is an asystole, meaning while pulseless electrical activity, it looks like a normal ECG, only that the person has no pulse and the patient is in cardiac arrest. So patient is cardiac arrest, you can see like an ECG coming, pulseless electrical activity. This flat line is asystole. It's not like the patient is dead. Don't do anything. No. That is only in movies that they'll say, pain, flat line, everybody should leave. No, that is not the case. You will continue your CPR. Then the VT with pulse and the pulseless VT we can see, and the VF. VF is jaga jaga. You don't have time to refer this patient. You must defibrillate as soon as possible. You must defibrillate as soon as possible. So just in your mind's eye, try and picture this. If you have a note pen and a paper, try and scribble it so that you can have some understanding or keeping of this, because you will need it and to be an emergency when it comes up. Please go on, Dr. Inuwa.
Okay, sir. Okay, so let's just have a short tests. Let's try and see if we can pick this rhythm. So this is somebody that is in cardiac arrest, meaning that there is no pulse. The person is not responding, no respiratory effort. You're doing your CPR, you put on your pads, you're checking your ECG tracings, and then you see this with no pulse. This ECG looks like a normal organized ECG. You know, you can see your P waves, you can see the QRS and the T. It seems like your regular rhythm, but this person doesn't have a pulse. Please, what do we think it's? What kind of rhythm is this? This is somebody in cardiac arrest. Can we put our answers in the box? Is it possible?
So I've launched a poll. Let us use the poll.
Okay, there's a poll.
Let us use the poll. Okay, I'm seeing different people. We'll stop the poll in another 5 seconds. Make an attempt. Don't worry, the poll is anonymous. We will not know what you picked. It's anonymous. It's only INEC that we know. So it's anonymous. Don't write in the chat box. Use the poll so that we can see what you have done and we can share it. We are stopping the poll in the next 5 seconds. Okay, 70 people out of 170 have clicked the poll. Let's click. So who is winning? APC, PDP, Labour? All right, so let's end the poll. And then let's share the results. I hope we can see the results. Most people chose C. Some people chose B. Some people chose A. So Dr. Inuwa, over to you. Most of them chose.
Okay. Okay, so first of all, I will try to explain why it can't be A or B, first of all, because I noticed some people chose that so that we are clear and everybody understands what's going on. So for A, it's ventricular fibrillation. If you can remember the previous slide, let me see if I can go back. Okay. It's not moving yet. Okay, but for ventricular fibrillation, if you can remember, we talked about the QRS being very broad and it was very irregular. We just saw like everything all over the place. It was very QRS. This is what we call QRS. You can see this complex here. You know, it was wider than this, more than 3 small boxes, and it was very irregular. So that's ventricular fibrillation. Then when we talk of pulseless ventricular tachycardia, still the same wide complex. We'll see it later. This is this ventricular fibrillation. We can see this complex is so wide. You can't even appreciate any P wave prior to this. And it's very, very fast. This is running at about 300 beats per minute. And you can see at times it seems the shape, the morphology changes, and then it's just, not organized, coming in at different irregular bits, So this is what we call ventricular fibrillation. But ventricular tachycardia, it's same, but, you can see wide complex, fast, but not as irregular as this morphology looks.
Okay, looks like we lost Dr. Inuwa, so I'll just continue from where she stopped. I hope we are clear about what she showed now. Hope we are clear about what she showed now. What she was showing now was Dr. Inuwa, are you back? So what she was showing now were the differences between the different types. So you know what, once you are back, just let me know. Once you're ready, just let me know.
Sir, can you hear me now?
Yes, I can hear you. Go ahead.
Okay, sir.
So share your screen.
For pulseless, you'll just see, it seems like it's a person, but the person doesn't have a, so it looks normal. Then for asystole, already has what seems like a straight line. You could see activity coming on, but it's so this is another, see we can all answer. Somebody in cardiac arrest, there seems to be like some activity going on here. Then all of a sudden,
I can't see your
put
screen.
your answers in the poll.
I can't see your screen.
Can you see my screen?
Yes.
Can you see it now? Am I still on?
I can't see your screen. You're on, but I can't see your screen.
Sir, can you still see the screen?
Oh, can we see the screen, please? Because I cannot see it. Maybe it's me. Just a minute. Sorry for the break in transmission. We're working on some technical things. Sorry. While we're at it, a number of people had cardiac arrest during Nigeria's match in AFCON. Some of us were at the viewing centers when those things happened, and some of us could not do anything.
Stay back to so no, sit here. No, don't. What's this?
So now we are showing you what to do so that it can work properly.
Please, sir, can you see it now?
Yes, we can see it now.
Oh.
We can see it now. So we're going to share a poll. So what activity is this? What activity is this? Where are my polls? Okay, well, if I can't find the post, just go ahead. What activity is this? You can write in the chat box. And write in the chat box. Some people said D. Some people said A. What activity is this? D. Some people are saying different things. Okay. Okay. So what pattern is this patient? The patient is not breathing, is not responsive. And then your ECG is there, you have been called. What can you see? So we'll stop in a few seconds. So I think most people are saying D, Dr. Inuwa. But some people said C, and some people said B. So Dr. Inuwa, over to you.
Okay, sir. So a lot of people chose D, which is right. It seems like a straight line, you know. You might see some little activity going on, but we already know that the person has no pulse. So once a pulseless electrical activity, that's the previous one we just saw, you don't CPR, continue to give you adrenaline, continue to you'll check your H's and T's, we'll go through it later on. But stable rhythms, the cardiac arrest rhythm with no pulse, non-shockable. So this was what I was trying to say, that those non-shockable rhythms, the two asystole, pulse, your CPR, you must continue to your CPR even though shock is not delivered.
So let me just highlight something.
Now we give IV 1 milligram every 3 to 5 minutes. Remember we said there's somebody saying give IV adrenaline 1 milligram. Hello, sir, are you there? You're trying to say something?
Yes, I want to highlight something. So some people only have AEDs. They don't have.
Sir, what did you say?
Some people have only AEDs. I think your internet is breaking up. Some people have only AEDs. That is automated external defibrillator, where you just put it on and you press on and it starts analyzing the rhythm. Okay, so for those people, you are doing CPR, it says analyzing the rhythm, it says stop. When it finishes, it now says non-shockable rhythm. That means it has analyzed the ECG for you. Some people think that when it says no shock advised, that means that the machine is not working. No, it just means that the machine picked one of these rhythms. I've had situations where nurses have come and said, no, their AED is not working. That is always saying no shock advice, that the machine is not working. No, if the machine says no shock advice, it means that the ECG the machine picked was either sinus rhythm and there's no pulse, or it picked this asystole flat line that we have shown. In that case, you go on. Don't say that you are seeing flat line in the movies. When they saw flat line, they close the person. No. Don't say that you did check the pulse and the pulse was at the eye, what do they call that, in pupil, and the pupil was dilated, and then you stopped. No. So I see some people want to do CPR, they just check pupil, they say our pupil dilated, they walk away. No. Pupils can be dilated for a number of reasons, and that does not mean the patient has passed. So you continue your CPR, and then you exclude the causes, check the 5 H's and T's, the different things that could have caused it, give adrenaline, continue CPR every 3 to 5 minutes, recheck again, give adrenaline, continue CPR, keep on rechecking the rhythm. Sometimes it will change from this non-shockable rhythm to a shockable rhythm, and then you continue. So just a note of warning to some people that feel that their machine is not working since it looks non-shockable. No, your machine is still working. That rhythm was one of these 2 rhythms. Over to you, Dr. Inuwa.
Okay, sir. So this is another cardiac arrest, no pulse. What do we think? We can see the QRS is broad.
I'm launching a poll. Let us try. What do we think? A, ventricular fibrillation. B, pulseless ventricular tachycardia. C, pulseless electrical activity. D, asystole. Based on what we have taught so far, please make an attempt. Don't worry, it's anonymous. Make an attempt It's anonymous. The patient has a cardiac arrest while you were operating and doing a CS or doing appendectomy. You looked at the ECG and then you saw this one while you were doing it. What do you think is happening here? A, B, C, or D? All right, we've had only 62 people have voted out of 178 or 100, almost 180 people. Okay, so keep on voting. In the next 2 seconds, we'll stop the voting. Make an attempt. Don't write in the box, use the poll so that we can see. Okay, so I'm ending the poll now. And I've shared the results. You can see, Dr. Inuwa, we are making progress, but we're not yet there. Some people still chose other things, asystole. In asystole, it is like flat line. It's like it's like a one straight line, maybe a few bumps up and down. Asystole. In C, pulse electrical activity, it looks almost like a normal ECG, only that this patient is having a cardiac arrest. So you see a normal ECG in a patient with cardiac arrest, what you are saying is pulseless electrical activity. So this is not a normal ECG. In D, pulseless ventricular tachycardia. If you can go back 2 slides back, in ventricular tachycardia, the QRS complexes are regular. They are going regularly. It's wide back. There's one that showed all of them together. You can see it. It is wide and it is regular. Ventricular tachycardia. And then in ventricular fibrillation, that's the one that I said it is jaga jaga. Everything jaga jaga. Ventricular fibrillation. Okay, remember Idris' song, Everything Jaga Jaga, that Obasanjo banned him for. That is how ventricular fibrillation looks. While wide complex regular rhythms, you are looking at VT, while flat lines, you are looking at asystole, and then for pulse electrical activity, you are looking at what it looks like a normal. Sorry, it's not on this slide. What looks like a normal ECG, except that the patient is having having a cardiac arrest. All right, so let's continue.
This is also an ECG tracing, also showing the ventricular fibrillation, but this is showing it in all leads. You know, when you're doing see only one lead, you know, but then that's why there's a need to do your full later on or while you're at it, and then you can appreciate it everywhere. You can morphology, but wide complex, you know. Other one, what do we think? Cardiac arrest, no pulse. We're still on no pulse. Breathing, you put your ECG leads and you are seeing this. You're seeing this. Please, what do you think? We obviously know there's tachycardia. There's about, it's moving on.
The poll is up. Let's try. We said cardiac arrest, no pulse. And we said non-cardiac arrest, there's pulse. Or it looks like the pulse is smallish, it's fast. Now we are going to the cardiac arrest rhythms. Sorry about the P and asystole tracing. That's a mistake. Sorry. It's within the slide formatting. That's not correct, please. Sorry about that. Dr. Olabisi Ogunbase. So what are you looking at? Yes, 65 people. So what we are looking at is that there's no cardiac, there's no pulse. The rhythm is wide, complex, is regular. There are no P waves. It is going consistent. So what are we looking at? Most people are ending the poll now, and we are sharing the results straight from INEX server. And we are seeing that most people are choosing B, which is correct. So the people that chose A, it is not particularly jaga jaga, but it is wide, irregular. It is not completely jaga jaga. Yes, sometimes a bit irregular, but more often than not, it is regular. So you can see what it looks like. So this is what we call a ventricular tachycardia. But in this case, there's no pulse. So it's a pulseless ventricular tachycardia. Sometimes a patient is having a ventricular tachycardia, but they have a pulse. They are in labor, they are in emergency room, they have ECG on them or their monitor, and they go into VT It goes on, people are looking at them until they stop breathing before people now rush. No, you must start treating this because it's a pre-arrest rhythm if they have a pulse. So I hope we can all appreciate that. Okay, anyway, we have to move a little bit faster because of time.
Okay,
so that
sir.
we finish in the next 30 minutes.
Okay, so there's a pulseless ventricular tachycardia and emphasis sake, pulseless, because you can have VT with a pulse. Remember, when you're having VT with defibrillates if there is a pulse. But if you're breathing, you are defibrillating. If there is a pulse with VT, then you are same thing. The only difference between the shockable rhythm and the non-shockable rhythm is that you are giving adrenaline. The 3 to 5 minutes will show you the algorithm. And after every 2 minutes of CPR, from one thing to the other, it could be shockable now, and then the next time you check it, you know, and then from the non-shockable rhythm, it keep rechecking after 2 minutes of doing CPR. You check there's room for IV amiodarone or lidocaine. The algorithm will be shown later on.
Okay, so somebody asked a question in the box that if it's for a child, what is the dose? So for a child, the dose for defibrillation is 2 joules per kg. 2 joules per kg for defibrillation, while you have to be writing. While for cardioversion is 0.5 to 1 joules per kg. But typically, it stay less than 50 joules. So 2 joules per kg or for defibrillation and 0.5 to 1 joule per kg for children for cardioversion in children. But you must know exactly what is going. So we'll go a little bit faster now. So if somebody has a cardiac arrest and you are doing ACLS, number one, check the rhythm, like we said. Well, let's say it this way: check the patient, check for the pulse and whatsoever. If the patient, well, cardiac arrest, the patient doesn't have a pulse, there's no breathing, the patient is not responsive. Now you've checked the rhythm. You have 2 sets of rhythms. One is asystole or a pulse electrical activity. That one, adrenaline, CPR, adrenaline every 5 minutes, and then you continue while checking for reversible causes: hypoxia, hypotension, tension pneumothorax, toxins, you know. You try and sort those ones out as you are doing your CPR. Hypoglycemia, you try and sort them out. Now for some others, you will see that VTAC, wide, complex, irregular, you know, like we said, ECG in that case, or VFib, jaga. In that case, you shock, you do CPR, continue CPR plus adrenaline every 3 to 5 minutes. You have to recheck again and then come back to the beginning, check the rhythm again, and decide again and continue. So next slide. So this is essentially what the cardiac arrest algorithm is about whenever somebody has had a cardiac arrest. The additional thing is that after second, third shock, you've shocked the first time, you came back, you continue CPR, you came back, you checked, you saw VFib again, you shocked the second time, by then start withdrawing your IV amiodarone. If you don't have IV amiodarone, you will likely have IV lidocaine, the same lidocaine you use to do local anesthesia. That same one, you can use that one, get the dose. You typically have to check the dose, and then you give IV lidocaine. So IV amiodarone, or you can after the second or third shock, and then you continue CPR and you continue your shock again in that regard. Okay, over to you. We need to move faster now. Thank you all for joining us. This is from Cardio Care. I can see over 180 people have joined us. Please go ahead.
Oh, okay, so I thought you were talking. Okay. So while we're doing the CPR, we're shocking in between. You know, you are running some tests, you are further assessing if there are any of the 5 H's or 5 T's we can see to address those things as we are continuing with the CPR. Because if the patient has any of this and you're not addressing it, you are not totally solving the. So as you're doing the CPR, you're doing shocking or not shocking, depending on what you're doing as needed. Then samples are taken, you're assessing if there's hypokalemia, checking the temperature, or there's need for blood, if the oxygen saturation, to know if it's a thrombus you're dealing with. That is why it's very important we do our dealing with ST elevation that needs to be addressed. If you are dealing with a tension in pneumothorax, you know you need to relieve it. And also not pull through. If it's a tamponade, you know you need to insert your tube in it. So, you know, if it's toxins, you need to give the antidotes. So every shocking, you are also looking out for these things so that you are also doing all that. Our hospital, and while the person CI, percutaneous coronary intervention, you know, the person just went in, you know, and then the shock resuscitating, you know, and we shocked the patient, sinus rhythm, and the patient is really do happen, and this happened.
A quick question to everybody on the call. If this was your patient, will you defibrillate or will you cardiovert? The patient suddenly loses a pulse, loses consciousness, and then you look on the ECG. Number one, what rhythm is this? Number two, will you defibrillate or will you cardiovert? This is a real life patient. This was maybe 2 years ago. I'm the one that shocked. The patient is alive, doing well today, walking around. Yes, let's answer in the chat box. If this is your real life patient, you are doing surgery for the patient, and you saw this ECG, no pulse, patient suddenly stopped breathing, and you saw this ECG, what kind of ECG is this? Can we answer? What kind of ECG is this? What kind of ECG is this? Is this an asystole, pulseless electrical activity, VT, pulseless VT, or VFib? Okay, so this is some people are getting it, some people are saying, so it's a pulseless VT. So pulseless VT, you will shock, just like you can see there's a shock there. Pulseless VT, you will shock. That shocking, is it defibrillate or cardiovert? Defibrillation, of course. You are not going to synchronize it. So pulseless VT, you defibrillate. You just put your paddles on the chest, and then you deliver the shock. Okay, 200 joules, 200, 360, and immediately the patient comes back to life and starts talking to you. Okay, so this is a VT. You can see it's wide complex. It is relatively regular for the first part. And then just before the shock, it started going towards VF a bit. Then the shock came in, and then it came back to almost a normal rhythm. The patient came back awake and started doing fine. So we did something for him. Please go ahead, Dr. Inuwa. We need to move faster, 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 faster.
And we'll have the slides later on so that we can print it out and put it in the hospital. It's something you can always look at to remind yourself. Emergency room. So this is all what we've talked about. When you activate funding, you know, you've called for help, you've told the person to bring AED, and as you're starting CPR, the person bringing the AED has brought the AED, you've attached the pads, you're checking the rhythm to see if the different ones. If it's the shockable one, you shock. If it's non-shockable, you continue with epinephrine and you're until you get your third shock, and there's room for amiodarone or lidocaine, as earlier explained. When it's a for 2 minutes, you assess again. You give epinephrine every 3 to 5 minutes for for both shockable or non-shockable. And this just continues going on and on until there's return of spontaneous circulation. If there's no return of spontaneous, once there's return of spontaneous circulation, then that's good. And we then know what next to do, which will be talked about later on. So moving on, let's quickly talk about the non-arrest rhythm. So these are patients that have a pulse, but the pulse is abnormal, or the pulse is greater than 130. You know, there are times when you see a patient with a pulse of 110, maybe the person is febrile and all that. Those ones that have pulse rates above 130, you know, and they are either stable or unstable. So it tells you that this patient is unstable. The patient is hypotensive, pulse blood pressure is less than 90/60. The patient sensorium, you know, you just know that the patient is just getting worse, you know. You need to cardiovert, and then you continue with medications. But for that 130, they don't have, they're just there in clinic. Maybe they came for the usual clinic follow-up. Maybe they are palpitations or chest, they might complain of palpitations, you know, they come to the, you're seeing greater than 130, they are very stable, nothing is wrong with them. You do their ECG, is in narrow complex. We talk about the amplitude of the QRS, you know, so that for narrow complex, there's room for vagal maneuver and then give medications. For wide complex, you go ahead. So if they are unstable and we want to cardiovert, we've talked about for the unstable ones, and you want to deliver shocks. The QRS complex morphology you're seeing is it narrow, regular. Then you want to do your 50. Will be your SVT, your superior ventricular tachycardia. So that will give you your narrow, regular, atrial fibrillation and atrial flutter. Then you want to shock with 120. Remember, these are unstable patients with tachycardia with a pulse. And if it's wide regular, you want to give your 100 joules. Your wide regular, that could be your ventricular tachycardia, but with a pulse, not the one that is without a pulse that you have to defibrillate. So we've talked about that, never defibrillate. All what we talked about, those that need synchronized cardioversion, either you're dealing with atrial flutter or the SVTs or AFib. We're trying to move on faster. I can't move on slide.
So this ACLS course is a full day course. We're just giving you an introduction so that you can have the full idea. If you were here at ACS, this would be a good follow-up for you. So it's just a short introduction, but it's a full day course. So I just give you something, so we probably will cover some and then leave some. So just try and follow up with it as we go on. We will send you the slides and we'll send you the link. We'll go to our YouTube page and subscribe to our YouTube page so you can watch the previous one that had more time, and you can rewatch this one over and over again. Go ahead, Dr. Inuwa.
Okay, so for those that are stable with tachycardia, they obviously have a pulse. You then want to use your antiarrhythmic medications, you know, depending on what you're dealing with. If it's a narrow complex, you prefer to use your adenosine. And adenosine is given in a very peculiar way because of its short half-life. You push and flush immediately. But first of all, you want to do your vagal maneuver, you want to do your carotid massage. If it's a narrow complex, please you have to move it.
Okay, so
if you're dealing with a narrow complex, first of all, you want to start with your vagal maneuvers.
Okay, so let me just say that when you are dealing with your ECG and you have a patient with pulse and his patient is stable, what we mean by stable or unstable is what we mean by stable or unstable is whether the patient has is whether the patient has, what we mean by stable or unstable is whether the patient has a low blood pressure, or that's what we mean by stable. So if we come back here now, the patient has a pulse is greater than 130. The next thing you ask yourself, is this stable or unstable? If they are unstable, they will have hypotension, they will have shock, they will have chest pain, okay? They could have an altered sensorium. Those are unstable patients with a very fast pulse. You probably need to cardiovet. While the stable ones will not have any of these things. They just came to clinic, you counted their pulse to 160, you did your ECG, and you saw that. So for the unstable ones, you need to cardiovet, like we talked about before, and give medications. For the stable ones, you are not going to cardiovet. You ask yourself, is it wide or narrow, just like in the unstable one? And then you start with vagal maneuvers and you give medications. So this is how you just differentiate it. Number one, the patient is having a very fast pulse greater than 140, greater than 150. AFib, atrial flutter, the different ones. Then is the patient hypotensive? Ask yourself the blood pressure. Any blood pressure less than 90/60 is hypotensive. Or in shock, you cannot measure the blood pressure. There's no, the person having chest pain or altered sensorium. Next thing you want to do is to identify the rhythm and cardiovet. Identify the rhythm and cardiovet. Okay, now if the patient is stable, you need to identify whether it's wide QRS or narrow. For wide QRS, sometimes you could be dealing with a VT. So that will be difficult to explain in this meeting. But if it's a narrow QRS, first start with vagal maneuvers. The vagal maneuvers are simple. Tell the person to do Valsalva, as if they want to pull, as if they want to push their baby out. Okay, they do that, or they close their mouth and their nose and blow hard against it. Or you give them a syringe or a bottle to blow into very hard. So they try and blow hard across that. It could end. Sometimes you do a carotid sinus massage, which is just to rub one side of the neck, not both sides of the neck. Oh, after you have checked for you can see me on the video. After you have checked for carotid with your stethoscope for a carotid bruit, there is no abnormal sound in the neck. Then you now put your hand over one, not two of them, and now massage gently. Typically, sometimes it should come down by itself. Otherwise, you go straight to medications. Okay, oxygen, monitors, ECG, specialist input. You're not sure what to do, and you're on our WhatsApp group. You can put it on our WhatsApp group. You can reach out to us, and we'll see how we can help to direct you. And then also keep on checking for the reversible causes, the H and T's, like we said again. So for the ones that are unstable, how do you cardiovet? If it is narrow and regular, 50 to 100 joules. That is like atrial flutter, all the other fast ones, 50 to 100 joules. If it is narrow and irregular, however, like AFib or the others, you will now give 120 to 200 joules. But in real practice, start with 50 to 100. You may actually get the person there. Otherwise, you start with 120 for the irregular. And if it is wide regular and you wide regular, patient is fine, has a pulse, you start with 100 joules and you gradually increase. Wide irregular is very likely to be a cardiac arrest. It's unlikely that you are feeling a pulse and you need to just defibrillate. But whenever you are feeling a pulse, never defibrillate. So we showed you all these ones. Now, these are the things we talked about that we just talked about. Amiodarone infusion. Okay, if you don't have amiodarone infusion, consider lidocaine, because amiodarone infusion is difficult to find. These other drugs are difficult to find in most parts of Nigeria. You can come to cardiocare and get them or look at them. Adenosine 2 is in cardiocare, but if you don't have it, consider lidocaine. You may be able to find a way out of it. Now, if it's narrow complex, I said vagal maneuvers, adenosine, but you must give it very fast because it only lasts a few seconds and it can disappear from the body. IV beta blockers, calcium channel blockers. This is not the one that you give orally, except you are in the village and there's absolutely no hope. Okay, so it's not what you give orally because, but if the patient is stable, you can try giving orally, at least to help the patient till they can get to a specialist center. Then you continue to monitor, treat reversible causes, and then if it try and do other things. Now, what will you do if the pulse is slow and the patient has a pulse? Observe, check, so pulse is 35, 40, do an ECG, treat reversible causes, and start preparing for for permanent pacing. So if they are stable and they are pulse, so somebody comes to you and check their pulse is 40, they are fine. Do an ECG, investigate them, check for reversible causes and treat them. If you look at it and you see a complete heart block and that's irreversible, you need to just plan for permanent pacing. Now, if the patient comes in and is unstable and the heart rate is very slow, they still have a pulse, heart rate is 25, patient is hypotensive in shock. Number one, atropine. We all have atropine. So right now, you already know what you should have in your emergency trolley. It should not be locked up in the matron's office. It should not be locked up in the MD's office. It should be available for everybody to give. Okay? So atropine, 0.5 to 1 milligram. You give it as a bolus. Every 3 to 5 minutes you give. Total dose of 3 milligrams. Don't go more than that. Okay? While you are giving it, start preparing for the pacing. Then you go to transcutaneous pacing. That same device that we showed you, you likely should have it in your different hospitals. Some hospitals have it and it's locked up. Some other hospitals, a lot of hospitals don't have it. You can use it to do transcutaneous. That is, you can do it, turn it to a pacemaker and move the patient safely to cardio care or similar facility that can put a pacemaker. If you don't have transcutaneous pacing, after your atropine, now put adrenaline infusion or dopamine infusion. Okay, so that's what you should move on to next. That's what you should move on to next. So adrenaline or dopamine infusion is what you should move on to next. So atropine, adrenaline is not working, you can add dopamine infusion. If you have transcutaneous pacing, start transcutaneous pacing, and then now get them in. So let's look at the summary again. First part, we said cardiac arrest rhythms. No pulse, patient is not breathing or patient is gasping, patient is unconscious. You have one of these four: VT, pulseless VT, VFib, electrical activity, and systole. The first two are shockable. You need to shock, continue CPR, give adrenaline every 2 to 3 hours, and after the second to the third shock, give amiodarone after the second to the third shock, and likely continue infusion. If, however, it's non-shockable, start checking for the reversible features, and then continue CPR, give adrenaline, give atropine. Those as how you treat. This is the summary of ACLS. While you prepare for intubation and other advanced airways, you call in everybody, call for help, everybody is coming in. Now, for the people that are not in arrest, they are awake, they are alive, but some are stable and some are unstable. We say anybody that has a low blood pressure, is in shock, has chest pain, heart failure, or altered syndrome is unstable. While those that don't have any of these, they are stable. So for white complex tachy and they are stable, give medications. And we listed all the medications which you can give IV. And if they are bradycardic, you can give medications. However, if they are unstable and if heart rate is fast, you need to cardiovet. If they are unstable on bradycardia, you need to prepare for permanent pacing. But we said start with atropine, then start transcutaneous pacing, and then you might continue with adrenaline or dopamine infusion if you're not getting enough, till you can get them to a center like cardio care that can put in a permanent pacemaker urgently. Okay, and then we'll go to post-arrest care. So we had to rush a little bit, but you can watch it again, and then now, if you finish ACLS and you don't take care of the person after the cardiac arrest, it's like rescuing the person from one ditch so they can enter another ditch. They will still die. You finish all of these fantastic things and the patient is now alive. You should move the patient to ICU. You need to consider putting an airway if they had an arrest. You need to measure the respiratory parameters, manage hemodynamics, obtain a 12-lead ECG. You know, if there's STEMI, if there's stroke, if there's cardiogenic shock, you need to call for specialist care. You need to take to the ICU, bring down the temperature, and all of these things must be done. Don't just say, hallelujah, the patient is back alive, and then you now go to sleep. No. That patient will not make it again. Patient has brought him out of one ditch. You need to take him all the way till he gets to safety. Okay, so if patient had a cardiac arrest, ventilation is typically recommended. You put the patient, ventilate. You cannot ventilate, move to an ICU. Treat reversible causes, then get specialist input, and then advanced airway like the anesthesia. Now, the other things that can be done, which are all part of ACLS, PCI, stents, patient is having a heart attack and they had a cardiac arrest, you sorted it out temporarily, you need to go and put a stent to open that up. You cannot assume that, okay, no, the problem is still there. And there are other things that we can do here in cardio care for your patient. Pacing, IABP, all are available in cardio care for your patient. All your hospitals, everybody watching, all 180 of you that are online now, must have a crash cart and must have all these things in your trash carts. You must have multiple in your hospital. Take a picture of it, snap it, whatsoever. Get all of this. Get them. Nigerians can survive with people that know what to do when they have a cardiac arrest. So that is that. So we'll go through a few questions. Dr. Inuwa, I think we should go through these questions, or we should just end the case here. Pamela, do we have enough time to go through these questions, or we should just end here?
Pamela. He's asking, do we have enough time
to take some more, or we should just end here? So
I think we can take one case or two. So
okay. So you said what?
no, she said we have like 27 more minutes, so maybe we can take some questions.
Okay, so in the chat box, you see the link to join the WhatsApp group, so you can do that. Let me just take a few questions if we have not answered them. Okay.
So we could go through the cases.
Okay, well, I've gone through all the questions actually. All right. So 52-year-old collapsed at a rally. He arrived at your hospital, BP is 60/30. SpO2 is 95%. So all the doctors are here, all the nurses are here. Now, the patient now comes in and has a steady pulse. What will you do next? What will you do next? So we can answer it here. 52-year-old, steady pulse, initial steps, 60/30. What will you do next? Collapsed, rushed in. You know this person a rally person. This could make your life, or could break you. All right, let's vote. We are coming to the end of this. Only 13% of us have voted. Don't worry, voting is anonymous, so just try. All right, so let's end the poll now, and then we'll share the results. Dr. Inuwa, we have work to do. People need to watch this thing over and over again. So we have, most people chose C, some people chose B, some people chose A. Some people chose A. So this were our results. So the correct answer is C. So most people were correct. Patient has just come in. You don't have an ECG, so you cannot go and start cardioverting. You don't have an ECG, you don't know what the rhythm is, so you cannot go and start giving adenosine. You need to first check that the person has a line, the person is breathing, check the airway, check all those things. You need to do some basics, get the person in, connect your ECG, find out from history as the person is there, the person is still awake and talking to you. So that's what you need to do first. Okay, you now saw this ECG for the patient. Can we all see the ECG for the patient? We saw this ECG for the patient. We can all see the ECG for the patient. So now let's do another poll. Based on this ECG for this patient, what will be your next step? The pulse is steady, blood pressure is 60/30, SpO2 is 95%. What will you do for this patient? All right, there's a poll on. Let's click. Let's choose. Let's vote. Anonymous voting. PDP, APC, LUP, Labour Party. Which other one again? Parties again is there. I've forgotten the parties. NMPP, PRP, platelet-rich plasma. Okay. 34% of us have voted. We'll be stopping the poll in the next 2 seconds, and we end the poll. So let's share the results. So Dr. Inuwa, we have different, 24% said defibrillation, 3%, 3 people said, 61% said cardioversion. Somebody said all of the above. 4 people said all of the above. No, you cannot do all of the above now. And then somebody said A, amiodarone. So let's see. Have I shared the results? Everybody has seen the results, Abby? Okay, I think we have seen the results of the election. So let's stop sharing and then see. So why are we saying cardioversion and not defibrillation? This is the ECG for the patient. The patient has a pulse. Patient has a pulse. So this is a VT, a VT with a pulse. It's not a pulseless VT. So remember, never defibrillate anybody with a pulse. We said that before. Never defibrillate anybody with a pulse. Instead, you cardiovert. Your cardioversion will synchronize all of these and it will deliver the shock with the QRS. So that is what you want to do. So never defibrillate anybody with a pulse. You cardiovert first. Amiodarone will be too slow to work. So you don't start amiodarone. You cardiovert. Defibrillation will give you such a high dose and to give it at any time. So we don't want to do that. Okay. So if you're going to cardiovert, what is the dose?
Sorry, sir. The previous one, somebody said it looks like. Explain again. Somebody put up in the, yes. Somebody.
Okay. So we have a wide complex tachycardia. It is relatively regular. It is not jaga like a VFib like we showed the last time. It is relatively regular, wide complex, going continuous like this, and the person has a pulse. So remember that we say there are 2 types of VTs. This is a ventricular tachycardia, VT. The one with a pulse and the one without a pulse. The one without a pulse is a cardiac arrest rhythm. The patient will not be talking to you. The patient will be gone, not breathing, no pulse. That one you need to defibrillate. However, this person is talking to you. He's still telling them to transfer money from his account. Pulse is steady. He just came from a rally, and you can see him weak, unstable with this wide, complex tachycardia. So what you do is to cardiovert, not defibrillate. So that's what I mean. So what dose are we going to use here? So we have 3 options. What dose are we going to use here? Let's use the poll. What dose are we going to use of cardioversion? Cardioversion. What dose are we going to use of cardioversion? What dose are we going to use of cardioversion? All right, so let's end the poll. Let's share the results. Yes, most people got the answer, 50 to 100 joules. Remember, we said regular, wide complex, 50 to 100 joules. By the time you are getting to 200 joules, you are getting into defibrillation a lot of times, okay? So we said cardioversion, the difference between cardioversion and defibrillation is that cardioversion is lower dose, defibrillation is higher dose, okay? So that's what we said. We're not getting to 360 yet. No, that is no longer cardioversion. You're entering defibrillation. All right. So let's go a little bit faster. So you attended cardioversion. Unfortunately, the patient now has lost a pulse. Gang. You killed him. You killed him. Everybody is shouting at you now. What do you do next? Okay. I hope we are following this our nice story. What do you do next? So the patient has lost the pulse. What is your next step? What is your next step? So what do we do now? Something is not launching. Okay, just a minute. Okay, fine. So let us vote. What do you do next? Now the patient has lost the pulse. Dr. Adibaba Bieku, what's happening here? Do you know who I am? Somebody is asking you. You start sweating inside room of AC. There's headache at the back of your forehead. What was your next step? You try to call Dr. Iseko and try to call cardio care, but MTN tower was down. All right, so what do you do next? I hope I'm making it. 34% of us have answered. 34% have answered. So next step, I've ended the poll. Next step, this is what everybody is saying. Most people are correct. So you cardioverted, now they don't have a pulse. Someone does not have a pulse, you do not cardiovert again. You are now defibrillating. You have entered cardiac arrest. Remember what we said about cardiac arrest rhythms? Who remembers? Let me see whether I can come to it. Where is that? Yes. So you have, is it this one? No. We said when you have cardiac arrest and you have that, what you do, you don't start with amiodarone. You start, and you have seen that it's not a VFib. There's no pulse, or it's not a pulseless VT. Remember the other one was a pulse VT. Now there's pulseless VT. You shock first and continue CPR. It is after your, and give adrenaline every 3 to 5 minutes. After your second or third shock that you bring IV amiodarone. It's after your second or third shock that you bring in IV amiodarone. So you shock first, and then you continue your CPR. So just for those that did not get that question. So you shock first, and then before you continue your CPR. So shocking, that defibrillate. You defibrillate. You've already cardioverted. Now there's no pulse. So you cardiovert. It's until your second or third one, and every 3 to 5 minutes you add adrenaline. You don't start giving adrenaline immediately. And please don't go and start giving adrenaline inside the chest. It doesn't work. Okay? So initiate CPR and then you start shocking. Before the CPR comes, please, before the shocker comes or the defibrillator comes, please continue CPR. Okay. So after a while, so now no pulse still. Blood pressure is now 40/20. SpO2 is query over query. The pressmen are guarding outside. They've already announced it on Instagram. Then Guardian has called themselves back. But Dr. Ajangbadi is still in the ER. And he has attended this course. So what will he do? So let us choose. Let us choose. Among these 4 options, what will you do based on what we have taught? Based on what we have taught. No pulse, had previous VT, you have shocked ones, it's still remaining like that, you have continued CPR, so now what will you do next? All right, 37% have answered, and this needs to go to the Supreme Court to decide this INEC vote. So we have A, we have B, we have C. So what is the correct answer? What is the correct answer? The correct answer is C. So we said adrenaline every 3 to 5 minutes. Then amiodarone after the third shock, and then you continue CPR. The first dose of amiodarone is 300 milligrams, and then the second dose is 150 milligrams. So amiodarone is typically 300 milligrams. Then if you have to give a second dose, it goes to 150 milligrams. So 300 milligrams. So this is what you do as you are continuing, and then you continue your CPR. Okay, so and I think we may have to stop here. You can go to our YouTube page and watch it. Just as a summary again, remember that you first assess your patients. CPR, basic life support must be done first. Crisis resource management, every team member should be assigned. Rhythm should be identified. You need electrotherapy, that is either cardioversion or defibrillation, medications. Then you need people with advanced airway to intubate, and then you need other specialized things like a pacemaker. You need things like PCI in the stents, like we do in cardio care, and that will really help. So that's a summary of it. And then we also said that.
Sorry, sir, can you hear me?
Yes, I can hear you.
Somebody asked why not atropine?
Okay, because
that
when
last case,
we did
yes,
not talk
sir.
about atropine in
Yes.
that. Remember, we said atropine is for bradycardia or for pulse electrical activity, not for VT. If you give atropine will fasten the VT and kill the patient faster. So remember, the patient started with VT, went to pulseless VT. Now we are shocked with VT, and we are still seeing VT on the screen. If you give atropine, the heart will go faster. That is why sometimes people are just doing CPR without a monitor and giving atropine, and if they are going to worsen it. Okay, so I was going through this. So the normal CPR, airway, breathing, circulation, but circulation comes first though, before airway and breathing. Then we now confirm the situation, call for help, compression, just the normal things, then airway ventilation, defibrillation. You have leadership, communication, and preparation. Then decide whether it is a cardiac arrest rhythm, no pulse, or a non-arrest rhythm, it has a pulse. Of the cardiac arrest rhythms, some can be shocked and some cannot be shocked. The ones that can be shocked, one is jaga jaga and one is a wide, complex, regular rhythm, relatively regular rhythm. And for the ones that cannot be shocked, it's either it's a flat line or it is looking like almost a normal ECG or just very slow. You need to now do that. Now for the non-arrest rhythms, you have very slow heart and you have very fast hearts. Of the fast heart, we look at the QRS complex, and it could be a wide complex tachycardia like a VT with a pulse. Those ones, we ask ourselves whether the patient is stable or unstable. If the patient is unstable, we go on to other things. So check the rhythm. If it's asystole or pulse adrenaline or an CPR, okay? Sometimes you add atropine in that one. But when it comes to VT or VF, shock, CPR, and then you continue your CPR, and then you now add adrenaline every 3 to 5 minutes. Be checking your H and your T's, and then add IV amiodarone after your second or third shock. And if you don't have amiodarone, give lidocaine. If it is a pulse, is unstable, if they have hypertension, cardiovet, and then medications. If they are stable, if it's a wide QRS and they are stable, you need to now stable wide QRS. Typically, we go towards medications. But
Sorry, sir.
yes, please.
Hello, sir.
Yes, please.
Somebody asked, can we give lidocaine? So just for emphasis sake, it's either amiodarone or lidocaine. Lidocaine is 1 milligram per kg. So it's either we use amiodarone or we use lidocaine.
I call lidocaine because lidocaine is likely more readily available than amiodarone if you don't have amiodarone. So I'm just going through a summary of the entire thing, and then you go through that. So thank you all for joining us. Pamela has a short presentation for us. Let me see if there are any other questions. CPR ratio, yes, it's still 30 to 2. It's still 30 to 2. Somebody say, why the change in CPR ratio? It's 30 to 2. Really, what happens is that every 2 years, a new update comes up, and it's based on studies. Elsewhere, people are measuring everything and checking what worked and what did not work. And so they're improving and improving and improving based on what is happening and what is working. So that is how they keep on changing. That's why now it's now circulation first before airway, unlike before. Okay, so Pamela, over to you. Once again, thank you very much for joining us. You can refer your patients to cardio care. We do quite a number of services. And this is our way of saying that, look, Nigeria can be better. And if all of us put our hands on deck, our patients can actually get well. These things are not everybody knows them. Not everybody is doing them. And you can see they are quite easy. Patients can actually survive. Either it happens in theater, it happens in the labor room, in after emergency room. That is what can happen. So in such a situation, these are things that you can do before you even refer to us. Cardio care in Abuja, Central in area 11 near the FCT minister's office, Wiki's office. You can send your patients there. We could put stents, pacemakers, do lots of wonderful things. So patients don't have to travel abroad. They can get the best care here. In any case, all the things we talked about, you must do your part. and then now start transferring them for us to now complete what is necessary to keep the patient alive. Okay, so I'll be signing off now. Thank you very much. Pamela, please go ahead as we round up this presentation. You receive your CMEs and the slides and a link to the video in your email, the email you used to register, and that will be great. And then we can get across to you. You may also join the WhatsApp group. Pamela will give you some more information on how to maximize what CardioCare is doing for us all. Thank you very much. Pamela?
Yes, sir. Good evening, everyone. Can you see my screen?
Yes, you can see your screen. Please, you have taken it off now. All right, so CardioCare is known for a lot of things. We founded in 1982, 40 years. Our main hospital and CardioCare in 2016. That's the Minister of Health at the official launch of our cath lab. Like 5 years ago, we've done over 1,000 cases, put in lots of devices. This is a patient with heart failure that needed devices, and you can see the case we discussed today. So a lot of the patients that have a cardiac arrest will need a device to help them and stop them from having another cardiac arrest. And this was his ECG after, much better. And this is a patient, I'm sure we all know what this is. This is a patient that was referred to us last year. I'm sure we can make this reading. This was picked in the referral hospital before sending to us. So this is a tachycardia, right? It is 150 beats per minute, very fast. It was unstable, and it is wide complex. Wide complex, almost regular. This is what we call what? You can put in the chat box. What is this one?
Good evening, everyone.
Okay, Pamela, you are able to talk. We're not hearing it before. So this is a ventricular tachycardia. So
good evening, everyone. My name is Pamela, manager. Currently going to give a brief presentation on referral and partnership options available at the CardioCare Multi-Specialty Hospital. If you can see my screen, just a brief review on who we are. CardioCare is a multi-specialty hospital focused in cardiovascular and internal medicine specialty. We are located at number 5 Giza Close, Area 11, Gariki, Abuja, an award-winning healthcare institution for excellence in cardiovascular care. And we're also dedicated to reversing medical tourism. We support hospital and national referral center to hospitals, doctors, and other training institutions. And our focus at CardioCare, our focus is to provide safety, effectiveness, patient-centeredness with international globally accepted standards. Some of our offered services are in cardiology, interventional cardiology, endocrinology, and other specialties of internal medicine. Our advanced care includes coronary angiography and interventions, peripheral angiography and interventions, cardiac device implantation and programming, structural heart interventions, thromboembolic therapy such as IVC filters, cardiac surgery, kidney transplant, critical care, and advanced cardiac investigation. Some of our non-invasive assessment services include Holter, spirometry, stress, ECG, EE. So some of the services that we have started not long ago at the cardio care, includes cardiac thoracic surgery. And then with partnership with the Limit Children's Hospital, we are going to be making available pediatric interventional cardiology and then structural intervention, like I mentioned earlier. Some of our facilities include, we have 24 bed space, VIP suites, private suites, general suites. We have 2 intensive care units, the HDU and the ICU. We have theaters, cath lab theater, operation theater, and then we have the dialysis suites. We have the physiology lab and then the radiology lab. Some of our management team include, we have endocrinologists, we have a neurologist, we have interventional cardiologists, and the rest of the team at the clinic. Now, this is the most important part of what we do because we're a healthcare institution. These are some of our training that we've done. That's the 1st to 7th annual cardiovascular symposium, which currently this year we're going to be having the 8th edition. We also hosted the 1st International Interventional Cardiology Symposium, that we call it the NICS, for residents and cardiologists that are interested in interventional cardiology. We also have the cardiovascular disease seminar. We have our monthly webinar, which is the one we are currently doing now. We have a hospital presentation at government healthcare and facilities. And then we have our weekly CPD at the cardio care hospital. And then some of our milestones include, we've done over 1,000 cath lab procedures. We are globally recognized as an award-winning institution. And we are also open to research and collaboration. We have MOU with some government hospitals, the likes of OAU and some other teaching hospitals around the country, where they can send their residents, and we'll have some partnership where we can train them based on interventional cardiology and other aspects of what we do at Cardio Care Hospital. And we also are a training institution, and like I told you, we've hosted over 600 healthcare professionals via our monthly webinars and over 600 people through our annual cardiovascular symposium, like I mentioned, now in the 8th edition. And then why doctors choose cardio care? Number one, we give detailed feedback referral to referring doctors and facilities. We are open to collaboration. So we call you, we discuss the patient that you referred, and then at the end of the day, we send you a detailed referral feedback explaining breakdown of what was done at our clinic. Immediate intervention, so we are available 24/7. It's a state-of-art facility, so we used a fully computerized system. Expertise and experience with the success rate of over 100 interventional cardiology procedures, ranging from cardiac device implantations to heart failure treatment. And lastly, opportunity to research and collaborate with the expertise at the Cardio Care Multi-Specialty Hospital. How to refer to cardio care. So you can either refer through a standard referral letter, preferably attach any valuable available results, of previous investigations. You can also send the person to come on site at number 5 Giza, area 11, Gariki, Abuja, or you can send an email to any of the email address on the screen. Or you can reach us via WhatsApp or call the numbers on the screen. And our advice, for every referral you're doing, please indicate your name, your number, your email, however we can reach you for collaboration and to discuss on your referred patient. And then lastly, we have a medical group on WhatsApp. My chief had already shared the link on the chat box. But if you have access to scan this code, it will give you direct access to the WhatsApp group, where we usually share cases, share ECG cases, share referred patient cases, or somebody you want to refer and you want to know how to get to us, or discuss anything regarding cases you're seeing, current trends in cardiovascular management and treatments and all of that. So that is what we basically do on this group. You can scan the code here and then join us on WhatsApp. You can also get notification regarding upcoming events, upcoming webinars, and what we are doing in terms of training. Yeah, you can connect with us through any of the available means on the screen. You can email us at info@cardiocare.ng, or you visit the hospital, or you can call the number on the screen. Yeah, so we had an opportunity to do this cardiac device outreach last month, and it was a very huge success because we achieved another milestone through the cases that we saw at Cardiocare with the collaboration of Cardiovascular Education Foundation. We were able to give discounted cath lab procedures to financially disadvantaged patients. Thank you so much for joining us today. Our vision to curb medical tourism is incomplete without your collaboration. Let's do it together. Let's support your practice for better patient outcome. We would like to partner with you. Cardiocare Hospital Abuja appreciates the opportunity, to be here and to, discuss with you. Let's support your patient with world-class cardiac solution. And once again, thank you so much. My name remains Pamela Ohaneje from Cardiocare Hospital. Thank you. Dr. Iseko. Sir.